Okay, good morning all. We will start with a few questions in asthma. Which of the following is not required in case of second puff to be taken from an inhaler? So what should be the answer? Okay, so this is actually particulate matter which is kept in a compressed chamber. Okay, so whenever compressed chamber is there and particulate matter is present, what will happen is there will be sedimentation. Okay, so you should always shake the container before dispersing the drug. Okay, so it has to be shaked well. Okay, and wait for 1 minute before taking puff. The procedure is the patient should take a deep inspiration followed by deep expiration. Then he has to keep the uh, nozzle of the dispenser over the mouth. Okay, and he has to give a tight seal and give a deep inspiration. Okay, so the deep inspiration should synchronize with the pressing of the chamber. Okay, so he has to take one puff, keep it there, and then again he has to take a deep inspiration for the second puff. Okay, so he has to take some amount of time to keep the uh, uh, to make the particulate matter to deposit over the throat and the airway. Okay, then keep the mouthpiece dry. Okay, the mouthpiece should always be kept dry, because when it is wet, what happens when you press the chamber, what will happen? The nozzle will get all the deposits. Okay, that should not happen. So you have to wash the mouth after completion of the whole process of dispensing the drug. Okay, so that is the answer here. This is little old question. Okay, all are true about aspirin sensitive asthma except. So aspirin sensitive asthma is associated with samterstride, right? Samterstride. So samterstride, we saw three things. Okay, one is nasal polyposis, sinusitis, aspirin sensitivity. Okay, and I told you that in aspirin sensitive asthma, the treatment is going to be low dose inhaled corticosteroid more than SABA. We all know that whenever your aspirin is given, it is going to inhibit the COX pathway. So prostaglandin production will decrease and LOX pathway is activated and leukotrienes will be increased. So answer is going to be increased prostaglandins. Okay, increased prostaglandins. Okay, that will be the answer. Okay. 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 Which of the following drug is not used in severe persistent asthma? Oral corticosteroids is the last resort of treatment. Okay, so you have to go for long-acting beta agonist, inhaled dose steroids, as and when required. SABA is a second-line drug, and the last treatment is going to be oral corticosteroids. Okay, last treatment is going to be oral corticosteroids. Drug of choice for type 2 brittle asthma: subcutaneous epinephrine. Okay, subcutaneous epinephrine. One of the following is not an indicator of severity of asthma. So we saw a lot of things, right? So those differential points is important, and more than that, what are the components which you use in assessing a patient in acute exacerbation of asthma is very, very important. Clear? So what are the things we saw? Accessory muscles. Okay, I told you that in initial part accessory muscles will be more active, and once patient goes to respiratory arrest, accessory muscles will not work. Okay, so accessory muscles is one component. Second is pulsus paradoxus. I told you pulsus paradoxus and explained the same. Okay, then third is systolic BP. Cyanosis. Which one is there? Systolic BP was not a component of that thing. We saw tachycardia, relative bradycardia, we saw tachypnea, and we saw cyanosis, but this is not a component. Okay, so whenever you have any patient with severity of asthma, I told you that as the disease progresses, cyanosis can worsen and it will go to a level there patient will have total shutdown of oxygen supply to the lungs. Okay, then aspirin sensitive asthma is associated with this, also very easy one, nasal polyposis. It is also called as intrinsic asthma. It is not associated with atopy. Okay, and obesity is not a component of it. Okay, best treatment for exercise induced asthma. low dose inhaled corticosteroid. Okay, so all these questions are recent repeat questions. Okay, commonly used route of administration of omalizumab in asthma, subcutaneous route. Okay, subcutaneous route. Okay, so we will see this question. Okay, we'll just come to that again. I will show you again this question. This is little we have to discuss COPD and then come. Okay, this we didn't discuss, but again. So whenever you have any patient coming to you with asthma, I told you that we have stepping up and stepping down the treatment. Okay, from step 1 to step 2, step 2 to step 3 we will go, until step 5 we will go, and step 6 is the additional drugs like inhaled oral corticosteroids or parenteral corticosteroids is being given. Okay, so whenever you advance from step 1 to step 2, you have to advance whenever your patient is having increased symptoms or persistent symptoms. Okay, whenever patient is saturation is less than 90%, okay, and patient PaO2 is less than 60, okay, then if it is present, then you'll go to step from step 1 to step 2. Okay, and if the patient is in step 4, for example, okay, step 4 means what is the drug we are going to give it? A high dose, so medium dose corticosteroids, right? So medium dose corticosteroid, if you are giving medium dose corticosteroid, what is the problem with medium dose corticosteroid? It will have more side effect than the step 3. Okay, so you have to give the minimal dose which is patient is tolerating, right? Minimal dose which is patient is tolerating. Okay, so for 3 months, if the patient is symptom free, then you can step down the treatment. Okay, if 3 months the patient is symptom free, then you can step down the treatment. Okay, so this is called stepping up of treatment and stepping down of treatment. So what should be the answer here? So when patient has 3 months of controlled asthma, her long-acting beta-2 agonist can be stopped. Okay, long-acting beta-2 agonist can be stopped. Okay, so this is the thing which is where a patient with minimal tolerable dose, okay, and minimal side effect dose, the patient should be continuing the treatment. Okay, again, if patient is having, if you're going to step 2, okay, if patient is tolerating step 2, then what you can do is you can go back to step 1. As and when required, low dose inhaled corticosteroids can be given. Okay, and if the patient is symptom free with even with as and when required, then you can give a trial of stopping the drug. Okay, if symptoms recur, then you go again to step 1. Okay, that is how you have to treat. But what happens in contrary is all patients, okay, will have one inhaler, and that inhaler patient will be taking continuously, because the patient will not be told how to step up and how to step down. Okay, so that is biggest problem what patients with asthma face. Okay, so it is actually, even if it is an oral drug or an inhaled drug, steroids has their own dose of toxicity. Okay, so you have to keep the patient on minimal dose of steroids. That is very, very important. A 30-year-old female referred to you after her recent hospitalization for asthma exacerbation. Specifically, she has 2 hospitalizations in the last 6 months. She has been on high dose of inhaled corticosteroid with LABA, montelukast, and oral prednisone. Despite this, she claims she needed salbutamol 4 to 6 times every day. She is recently started on PPA by her primary care physician. She demonstrates good technique with her inhalers. Besides obesity, other examination is unremarkable. Her lab tests are unremarkable except for serum eosinophils of 500 micro per microliter, and her chest radiography shows no acute pulmonary disease. Which of the following tests can test for control and compliance in this patient? So the whole story is not required. In asthma, which treatment is used for both diagnosis and following up? FeNO. Answer is FeNO. Okay. So whatever clinical question they are asking, most of the times, okay, if you see, there will be lot of stories, and finally the question will be, which of the following can be used as a prognostic marker? Which of the following can be used as the first choice of drug? Okay. So those kind of questions only will be more of clinical type questions. Okay. a 60-year-old female, a 60-year-old female, okay, this female comes with a history of asthma for 1 year, and despite treatment with oral high-dose inhaled corticosteroid in combination with the LABA, leukotriene receptor antagonist, and very frequently oral corticosteroids, she has symptoms daily requiring short-acting beta agonist and requires hospitalization once in every other month. She frequently runs out of a medication. Her exacerbation appear random and are not associated with any triggers, which you confirm with her asthma symptom diary, which is very meticulously kept. What type of asthma she have? It is actually steroid resistant asthma. Okay, so patient is on steroid, not responding to steroid, so which makes her to take SABA frequently, and with SABA or whatever beta agonist, she feels comfortable. Okay, what it means, the patient is taking prednisolone equivalent dose, okay, for 2 weeks and more than 2 weeks, and the patient is not responding to steroids. Okay, so this is actually a steroid resistant asthma, so it is going to be refractory asthma. Refractory asthma. Okay, so this is about your asthma. Okay, so next we are going to go into a topic which is going to be a condition where it is going to be preventable but irreversible. Once it ruptures, it is ruptured forever. Okay, and that condition is going to be COPD. Okay, so COPD is again one topic which is very useful in day-to-day life. Okay, so every time we diagnose or misdiagnose a patient as COPD, okay, and once he is labeled as COPD, he is going to remain lifelong COPD. Okay, so what is the definition of COPD? Okay, what is COPD? Okay, okay, so COPD is a preventable condition, treatable condition, but it is irreversible. Okay, here there is going to be airflow limitation due to abnormal inflammatory response. Okay, so if you take your asthma patients, it is airway hyperresponsiveness. Rather, here it is going to be abnormal inflammatory response. It's an abnormal inflammatory response which is going to cause a cascade of events. Okay, so if you take COPD patients, okay, COPD patients, the complaints with which the COPD patient is going to come to you is going to be an array of symptoms. Okay, there is no specific symptoms to say this is specific for COPD. Okay, they can come with whatever symptoms they can have. They will have chronic dyspnea. Okay, the patient will have dyspnea which has started some time back and it is continuing. Okay, as and when, okay, when patient develops some kind of infection or trigger, they will present with cough with sputum production. Okay, then they usually tell there is some kind of discomfort in the chest tightness will be there, and often whenever there is an airway narrowing, it is going to present as wheeze. Okay, and that wheeze is going to mimic a asthma. Okay, so again it is going to be misdiagnosed as asthma, and the patient will have history of again weight loss. Okay, weight loss because of chronic malnutrition, and being a chronic disease, the patient will have weight loss. Okay, so there are two types of conditions. Okay, one is chronic bronchitis, the second one is emphysema. Okay, emphysema. Okay, so two conditions associated is going to be chronic bronchitis and emphysema. Okay, so we will see the individual conditions later on. So what are the risk factors for COPD? Okay, the most important risk factor for COPD is going to be smoking. Okay, smoking. One reason is smoking, another reason is passive smoking. Okay, so now previously the male female ratio was male greater than female, but because of passive smoking and even first hand smoking, the ratio is almost equal nowadays, male and females. Okay, so the most important risk factor is going to be smoking. smoking. Okay, it is a major risk factor, and the risk increases with number of pack years. Okay, and one more thing is second-hand smoking. Okay, that is one important risk factor. Next is environmental pollution. So whenever there is winter season is getting over and entering into the early part of spring, okay, so every time Delhi faces that situation. Okay, whenever they are entering into the Baisakhi festival, that is Pongal, that time what happens, they will try to burn all the crops, weeds of the crops. Okay, so what happens, that air, okay, from the weeds, okay, that burnt weeds smoke will combine with the fog, okay, and it forms something called smog. Okay, the smog is one thing which makes pollution still worse. Okay, so smog and vehicle exhaust, okay, are one important risk for patients developing COPD. Next is combustion. Okay, so combustion of biomass fuel. Okay, so a lot of times female patients will come with history of COPD. Okay, so females, number usually where females are going to get COPD, why they are going to get, but what happens now, it is actually little less. Okay, one reason is cooking is less. Okay, so another reason is we don't use firewoods. Okay, so previously if you see any villages, if you go, okay, so what happens, they will have one small tube like thing. Okay, they used to blow air. Okay, when they blow air, what will happen, again the air is going to come back. Okay, when it comes back, they're going to inhale it again, they're going to blow. So this process is repeatedly happening, and because of that gas inhalation, the way females can develop COPD. Okay, COPD, so that is equal to smoking actually. Okay, so that is one important risk factor. And pollution from industrial exhaust. Okay, so industrial exhaust is also one important risk factor. Then next important thing is occupational. Okay, so whenever a patient is working in any mining industry, okay, even a farmer, okay, construction worker, all these people on long-term exposure are going to have risk for COPD. So these are modifiable risk factors. Okay, and these risk factors, if intervened, it can be prevented from progressing into next phase of disease. Rather, we have non-modifiable risk factors. Okay, in non-modifiable risk factors, we have gender. Okay, previously this disease was more common among males, but now the incidence is almost male equal to females. Okay, females. The reason being attributed is, one thing is first hand smoking itself, another one is passive smoking. Okay, then second, age of the patient. Okay, as age increases, the airway remodeling increases. Okay, as airway remodeling increases, there will be worsening of COPD. Okay, the third one is going to be alpha-1 antitrypsin deficiency, which I will discuss. Okay, Then next important is severe childhood lung infection. Okay, whenever you have severe childhood lung infection, what is going to happen is there is going to be again airway remodeling. Because of airway remodeling, what is going to happen? There is going to be airway narrowing. Okay, then Next one is GRD. Okay, GRD. Okay. Nowadays, it is postulated that GRD is one important risk factor for COPD. Okay. So the reason is, if you take here airway here like this and esophagus, what happens? There is going to be constant secretions. Okay, which is going to enter into the airway. Okay, which is going to enter into the airway. When it enters into the airway, what is going to happen? The airway will go for fibrosis. Okay, and that will result in airway remodeling. Okay, so for that reason only, whenever you have GRD, what they use? They use double probe 24-hour pH monitoring. Okay, so they will keep one probe over the opening of the esophagus, that is upper end of the esophagus, and one probe over the opening of the trachea. Okay, so what happens? It will monitor the pH at both the sides. Okay, when it monitors the pH at both the sides, what will happen? When the pH is equal on both the sides, it means that there is some kind of micro aspiration of acid. Okay, and it is measured by a score called, they will tell in gastro, de Meester score. Okay, they use a score for GRD called de Meester score. Okay, so this is one important risk factor. Okay, very important risk factor. Okay, I have recently I thought of showing one paper. So recently we like had a paper where GRD, if there in any patient who is having GRD, okay, or any patient who have COPD, okay, in COPD patients, if you check for upper GI scopy, there will be changes in the lower end of the esophagus indicating GRD. And in GRD patients, okay, if you go do PFT, there will be PFT changes in those patients. Okay, so that was a recent study which was done. I thought of showing you. Okay, so again, as I mentioned, there is lot of relation between GRD and COPD. Okay, so we cannot nowadays we cannot pass on as if it is not a risk factor. Okay, next is, as I told you, alpha 1 antitrypsin deficiency. Okay, what is this alpha 1 antitrypsin deficiency? Okay, so alpha 1 antitrypsin deficiency is going to be a condition where the patient is going to have emphysema. Okay, this is more common among people who are going to be this phenotype. And if this patient is a smoker, then it has additional risk factor. Okay, so what is this alpha 1 antitrypsin deficiency? Okay, if you take alpha 1 antitrypsin deficiency, there is something called alleles associated with alpha 1 antitrypsin enzyme. Okay, here we have few alleles. Okay, the first allele is going to be M allele. Okay, M allele means the enzyme is normal. Okay, then we have S allele. Okay, S allele means almost normal. Then we have Z allele. Z allele is deficient. Then next is N allele. N allele is absent. Okay, whenever a patient is having, whenever there is N allele, it means that it is absent. And whenever N allele is present, that is null allele is present, it means that patient cannot survive with that N allele. Okay, so here we have three combinations. Okay, one is pi mm. Pi mm means they have both allele as mm allele, and it is going to be a normal enzyme. Okay, and if they have MZ, okay, then it is going to be almost normal. This phenotype is almost normal. But whenever they have this phenotype, which is going to be PIS phenotype, okay, so this PIS phenotype is going to be deficient enzyme. Okay, whenever they have deficient enzyme, what happens is they cannot maintain the normal architecture in the alveoli. Why it is important? Okay, so if you take the lung, we have two types of enzymes. One is elastase, another one is anti-elastase. Elastase and anti-elastase. Okay, our alpha-1 antitrypsin is the one. Alpha-1 antitrypsin is one which inhibits this elastase and it stimulates the anti-elastase. Okay, elastase. Okay, it tastes the elastic tissue. That is, it tastes the elastic tissue or it destroys the elastic tissue. Okay, whenever your alpha-1 antitrypsin is deficient, what is going to happen? There will be increase in the elastase. Okay, and decrease in the anti-elastase. Okay, whenever this happens, what is going to happen? The elastic tissue in the alveoli will be destroyed. When the elastic tissue in the alveoli is destroyed, what is going to happen? The elastance property of the alveoli is lost. Okay, so only in alpha-1 antitrypsin deficiency we have emphysematous changes. Okay, emphysematous changes. Okay, so this is one important thing which you have to know. Okay, one important thing you have to know. Okay, now so additional risk factors, there is a table. Okay, so this additional risk factors, as I mentioned earlier, these are the additional risk factors which I am going to tell you. Okay, so what is the proposed etiologies? So I will write here another one thing. Okay, this is from latest GOLD guidelines. Proposed etiological classification of COPD. Okay, so here in this we have one, genetically predetermined COPD. Genetically predetermined COPD. In genetically predetermined COPD, we have alpha-1 antitrypsin deficiency. Okay, then second is due to abnormal lung development. Abnormal lung development. Okay, so abnormal lung development means it depends upon the birth weight, and low birth weight babies are highly associated with COPD in future, and premature birth are also associated with COPD in future. Okay, then third is environmental. Okay, where we have, as we discussed earlier, smoking associated. Okay, and another one is biomass fuel. Biomass fuel. Okay, then the fourth one, okay, is going to be COPD due to infections. COPD due to infections. Okay, here they have included a new infection which is going to be called as HIV associated COPD. Okay, apart from childhood infection, they have included HIV associated COPD in the new classification. Okay, then next is they have another one new disease, okay, which is called as asthma COPD overlap syndrome. What is this asthma COPD overlap syndrome? Is the patient who has childhood asthma, because of constant airway remodeling, they will have in future COPD. Okay, COPD. So these are the few classes which have been defined in the latest GOLD guidelines. Okay, latest GOLD guidelines. Okay, so this is again one important thing which can be asked in the INICET kind of exams. Okay, INICET kind of exams. Okay, so this is very, very important. Okay, so what is the pathogenesis of COVID? What is the pathogenesis of COPD? Okay, COPD. So as I told you, we have risk factors for COPD. Risk factors for COPD. These risk factors are going to cause inflammation in airway. So this is what happens. Okay. So whenever there is an inflammation, what is going to happen is there is going to be polymorphonuclear cell recruitment. Okay. And there is also going to be this inflammation causing certain changes in the airway, which is going to be squamous metaplasia. Because of the constant inflammation, the airway is going to go for squamous metaplasia. Okay. And there is going to be smooth muscle hypertrophy. Smooth muscle hypertrophy. Increase in the number of goblet cells. Number of goblet cells. Whenever there is an increase in the number of goblet cells, the mucus production increases. Okay. And whenever the mucus production increases, there is going to be productive cough. Productive cough. Okay. This polymorphonuclear cell recruitment increases the elastase content and increases the matrix metalloproteinases. Okay. And if this fellow has alpha-1 antitrypsin deficiency, then again the features worsen. Okay. So whenever this squamous metaplasia, smooth muscle hypertrophy, mucus gland production increases, resulting in productive cough, what is going to happen is ultimately there is going to be decrease in the airway caliber. The airway will go for narrowing. The airway will go for narrowing. Okay. Whenever the airway goes for narrowing, there is going to be airflow limitation. Okay, limitation. Whenever there is an airflow limitation, what is going to happen? There is going to be decrease in V and normal P. Okay. And whenever this happens, what is going to happen? VQ mismatch is going to happen. Okay. VQ mismatch is going to happen. Whenever there is a VQ mismatch, what is going to happen is the patient is going to have hypoxemia at rest. Okay. Hypoxemia at rest. Whenever the patient has hypoxemia at rest, what is going to happen? The patient PaO2 will decrease at rest. Okay. Whenever your PaO2 is decreased at rest, what is going to happen? It is going to stimulate the erythropoietin cells and it is going to result in polycythemia. Polycythemia. Okay. And at the same time, whenever there is hypoxemia at rest, what is going to happen? The patient is going to have pulmonary vasoconstriction. Whenever pulmonary vasoconstriction is going to happen, what is going to happen? Pulmonary hypertension. When pulmonary hypertension is there, what is going to happen? There is going to be cor pulmonale followed by edema. Okay, edema. Okay. Now, what happens? This patient develops hypoxemia at rest and edema. Because of hypoxemia in rest, the patient will develop cyanosis. So they will be blue in color. Okay. And because of the edema, their body will be little swollen. So they are called as bloaters. So these people are going to be called as blue bloaters. Okay. Blue bloaters. Okay. And what is going to happen? Because of the airway narrowing, we all know that there is going to be decrease in the ventilation, which results in hypercarbia. Okay. When hypercarbia is there, okay, slowly there will be decrease in the respiratory drive. Whenever there is a decrease in respiratory drive, what is going to happen? There is going to be increase in the PCO2. Okay. PCO2. So ultimately, the patient will have type 2 respiratory failure. The patient is going to have type 2 respiratory failure. Type 2 respiratory failure is going to happen in these patients. Then next is copy. Next is whenever there is a increase in elastase and increase in matrix metalloproteinases, what is going to happen is there is going to be destruction of the elastin. Yeah, CO2 narcosis. Initially, there will be stimulation. Later on, CO2 narcosis will develop. CO2 narcosis develop means patient will not respond to anything. Okay, so what is going to happen? Actually, here the work of breathing also decreases later on. Okay, only when increase in CO2 is there in initial part, patient will have increased work of breathing. As time passes, the work of breathing also will decrease in this kind of patients. Okay, so this is in, I'm telling, in later stage. Okay, not in the initial part of disease. Okay, then next is it destroys the elastin. Okay, whenever it destroys the elastin, what is going to happen is, so this is the alveoli, this is the blood vessel. We have elastic tissue in both alveoli and the blood vessel. Okay, both will be affected. Okay, when both are affected, what is going to happen is the patient is going to have capillary damage. When capillary damage is there, what is going to happen is there is going to be decreased perfusion. Okay, there is going to be alveolar damage. Okay, because of the alveolar damage, the alveoli becomes distended and there is going to be loss of elastic recoiling. It will be ballooned out. Okay, whenever it is ballooned out, what is going to happen is there will be air trapping and hyperinflation. Air trapping and hyperinflation. It means that there will be decreased diffusion. Okay, so what is going to happen? There is going to be decrease in the V. Okay, decrease in the V. And because of the decreased perfusion, there is going to be decrease in the P. Decreased V, decreased P. When both are decreased, it means it is matched for each other, right? So it is VQ match is present. VQ match. Okay. Whenever VQ match is there, what is going to happen? எவ்வளவு போகுதோ அவ்வளவுக்கு perfusion இருக்கு. So these patients are not going to develop cyanosis. If they are not going to develop cyanosis, they will look pink. Okay, they will look pink. Okay, because of the loss of elastic recoil. Okay, elastic recoil, what is going to happen? Every time he has to breathe deeply to open up the alveoli. Okay, it increases the work of breathing. Okay, whenever there is an increase in work of breathing, the patient is going to develop dyspnea at rest. Okay, so whenever he sits, what he is doing like that, he is breathing. Okay, so he is puffing out the air and they are going to be puffing out the air, and that is called as pink puffers. Pink puffers. Okay, so this is the cascade of events leading to pink puffers and blue blotters in patients with COPD. Okay, COPD. Okay, so where you get this pink puffers? Emphysema. Emphysema are pink puffers. Okay, where you get this blue blotters? Triple B. Bronchitis, you get blue blotters. Bronchitis, you have blue blotters. Bronchitis, you get blue blotters. Very, very important thing. Okay, so this is the reason behind patient developing pink puffing and blue blotting. Okay, blue blotting. So this is again very, very important thing. Okay, very, very important thing. Okay, so if you take your airway, copy it. If you take your airway, you have lot of changes in the airway which can occur in larger airways and smaller airways. Okay, so what happens in larger airways? So these are the larger airways. Okay, so in larger airways you have mucus glands more, so there is going to be goblet cell hyperplasia. Okay, because of that there is going to be mucus hyper secretion, and you are going to have sputum which is positive for inflammatory cells and neutrophils. So inflammatory cells are present in the sputum. Okay, inflammatory cells are present in the sputum. Then coming to smaller airways. Smaller airways. Okay, these smaller airways will go for thickening. There will be thickening of wall of smaller airways. And because of the thickening, what is going to happen is there is going to be disruption of attachment of alveoli. Disruption of alveolar attachment. Disruption of alveolar attachment. Okay, then in alveolar level, okay, so what is going to happen in the alveolar level? There is going to be an hyperinflated alveoli. Hyperinflated alveoli. Hyperinflated alveoli is present. Okay, and there is also destruction of the capillary bed. Capillary bed. Okay, ultimately leading to emphysematous changes. Emphysematous changes. Okay, so these are the changes which happens at the level of airways. Okay, so if you take the airway will have changes. Actually this has been asked twice in exam. Okay, which of the following is a change in larger airway, which of the following is change in the medium and smaller sized airways? These two things have been asked in exam. Okay, so in larger airways there is more of goblet cell hyperplasia and mucus secretion and neutrophil in the sputum. Okay, so this is what happens here. Okay, whenever your airway is normal, it is going to have a normal caliber, but whenever the airway is getting inflamed, it is going to get narrowed down like this. Okay, narrowed down like this. Okay, and this is what happens in the airway. Okay, you can see the mucus gland hypertrophy, smooth muscle hypertrophy. You can compare here: smooth muscle hypertrophy, goblet cell hyperplasia, and inflammatory exudates are present. Okay, inflammatory exudates are present. Okay, and all these changes are going to result in two conditions, which is going to be chronic bronchitis. Okay, then another one is emphysema, and all these are going to result in chronic hypoxia. This chronic hypoxia is going to result in pulmonary vasoconstriction, ultimately leading to pulmonary hypertension, leading to cor pulmonale. So what is cor pulmonale? Chronic lung disease resulting in heart disease or right heart disease. Okay, so because of this the patient is going to go for worsening. Okay, patient is going to go for worsening. Okay, so this is the ultimate complication. And if you ask me what is the most common feature or complication of cor pulmonale, is going to be chronic pulmonary thromboembolism. Okay, the most important reason for chronic pulmonary thromboembolism is going to be cor pulmonale. Okay, cor pulmonale. Okay, coming to the next thing which is going to be emphysema. So emphysema is of three types. Okay, so the first one is called as centriacinar emphysema. Okay, so before going into emphysema, what happens in emphysema is destruction and dilatation of gas exchange surface. Gas exchange surface. Okay, occurring distal to terminal bronchioles. What is the part which is distal to terminal bronchioles is called as respiratory bronchioles, alveolar ducts, alveolar sac. Okay, what is that part is called as? Acinus. So only they call it as acinus or acinar. Okay, acinus or acinar. Okay, so what happens to your airway is the airway will become like this. இப்படி இருந்தனா இப்படி ஆயிட்டேன். Okay, so the airway becomes like this. Okay, so you can see here which part is involved. The part distal to the terminal bronchioles is getting involved, and there is the dilatation of the airway exchange area. Okay, so this is called as emphysema. Okay, so here we have three types of emphysema: centriacinar, panacinar, and paraseptal emphysema. Okay, first is centriacinar emphysema. Centriacinar emphysema is the most common type. Okay, and it is associated with cigarette smoking. Okay, it is the most common part and most associated with cigarette smoking. Okay, then it is going to involve the central airway. Central airway. Okay, if this is going to be the terminal bronchioles, this is going to be the respiratory bronchioles, and if this is going to be the alveoli, okay, this is going to involve this part of your airway. Centriacinar emphysema involves the central part of the airways. Okay, and in the lung it is going to involve the upper lobe predominantly, involving the central acinus, especially respiratory bronchioles. Whereas if you take the panacinar emphysema, it is going to be seen in alpha-1 antitrypsin deficiency. Okay, and the chromosome associated with alpha-1 antitrypsin deficiency is chromosome 14, and the gene which is mutated is called as SERPINA gene mutation. Okay, so whenever this gene has gone for mutation, then you're going to develop alpha-1 antitrypsin deficiency, and it is going to involve the pan-acinus part. So it is going to be whole acinus is getting involved, pan-acinus. Okay, and this is going to involve lower lobe predominantly, and these patients having emphysema are relatively young patients, less than 45 years. Okay, and they will have no other risk factors, no other noticeable risk factors. Okay, and this alpha-1 antitrypsin deficiency will not affect only the lung, it will also affect other organs also. Okay, in the patients எப்படி present பண்ணுவாங்க, they can have history of vasculitis இருக்கலாம், liver disease இருக்கலாம், okay, pancreatitis இருக்கலாம். So they can present with multitude diseases. Okay, இந்த மாதிரி ஒரு காம்போ மாதிரி present பண்றாங்க. Young patient emphysema. If it is given in your question, or if you are seeing a patient, then it is going to be more towards pan-acinar emphysema. Okay, pan-acinar emphysema. Okay, pan-acinar emphysema. So this is pan-acinar emphysema. The last one is going to be paraseptal emphysema. Okay, paraseptal emphysema. If you take this paraseptal emphysema, these are relatively young patients. Okay, relatively young patients where the etiology is not known. Okay, young males for idiopathic reason they are presenting with emphysema. Okay, young males, idiopathic reason, they are associated with emphysema and they have recurrent pneumothorax. Whenever there is an emphysema with recurrent pneumothorax, then think about paraseptal emphysema. Okay, so what is this paraseptal emphysema? So if this is the patient lung, it is going to involve this part. Okay, this part is going to be getting involved, and this is called as paraseptal emphysema, and the patient will complain of recurrent pneumothorax. Okay, recurrent pneumothorax. Okay, so this is again a very, very, very important thing. Okay, apart from this, we have another one thing called cicatricial emphysema. Cicatricial emphysema. Okay, so whenever a patient is exposed to chronic occupational dust like silicosis, okay, quartz. Okay, whenever there is an exposure to quartz, what happens? This quartz will cause fibrosis of the lung. Okay, and what happens? It will pull the airway, more or less like traction bronchiectasis. Okay, ரெண்டு பக்கமும் scar இருக்கு. What will the scar do? The scar will start pulling the airway, and it is looking like a traction bronchiectasis or cicatricial emphysema. Okay, bronchiectasis on the terminal bronchioles. Adhe emphysema is distal to terminal bronchioles. Okay, and it is called as cicatricial emphysema. Okay, cicatricial emphysema. So என்னது ஒரு பேஷண்ட் வந்து ஒரு chronic lung disease இருக்கு because of occupation. Okay, fibrosis கேரக்டர் என்னது? ஃபைப்ரோசிஸோட கேரக்டர் ரிட்ராக்ஷன். ஓகே, when it retracts, இந்த ஒரு ஏர்வே இருக்குன்னா ரெண்டு பக்கமும் அது பிடிச்சி இழுக்கும். இழுக்கும் போது நாங்கள் ஏர்வே will go for dilatation. That is called as cicatricial emphysema. Okay, cicatricial emphysema. Okay, then you have giant bullous emphysema. Giant bullous emphysema. Okay, what is this giant bullous emphysema? ஓகே, இப்போ உங்க பேஷண்ட் கிட்ட வந்து பலூன் வந்து பெருசா இருக்கு. ஓகே, பெருசாயிட்டே போகிற பலூன் என்ன ஆகும்? அட் ஒன் பாயிண்ட் ஆஃப் டைம் வில் ரப்சர். ஓகே, இந்த நெய்பரிங் பலூனும் ரப்சர் ஆகும். ரப்சர் ஆச்சுன்னா இந்த மாதிரி ஒரு டைலேட்டட் இருக்கும். ஓகே, இது எப்படி இருக்கும் பார்க்கறதுக்கு? ஒரு பெரிய ஹோல் மாதிரி இருக்குமா? So this is called as bullous emphysema. Okay, they are called as bullae. Okay, and these bullae can rupture, leading to pneumothorax. Leading to pneumothorax. Okay, so this is called as bullous emphysema. So if you take the lung, okay, so here we have three types of emphysema. Okay, so one is going to be involving, this is a normal airway. Okay, and what is this emphysema? Centriacinar emphysema. What is this one? Pan-acinar emphysema. Okay, so this is centriacinar, pan-acinar. If you take this one, where is the dilatation? This is alveoli, this is airway. So only the airway is getting involved, respiratory bronchioles is getting involved. Then it is going to be centriacinar emphysema. Rather, if you develop like this, the whole thing is getting dilated, then it is going to be pan-acinar emphysema. Pan-acinar emphysema. What is this one? First one, center part is getting involved centriacinar emphysema. What is this one? Pan-acinar emphysema. What is this one? Paraseptal emphysema. Okay, paraseptal emphysema. Okay, so these are the three types of emphysema you get to see in patients. Okay, so three emphysema which is important is going to be centriacinar, pan-acinar, and paraseptal emphysema. Okay, so this is emphysema. Okay, then next we have another condition which is going to be chronic bronchitis. Chronic bronchitis. Okay, so if you take chronic bronchitis, okay, these patients will have chronic cough. How long the cough? 3 months. Chronic cough for at least 3 months for 2 consecutive years. Okay, so they are going to have chronic cough for more than 3 months in a year for 2 years. Okay, that is called as chronic bronchitis. Okay, chronic bronchitis. Whenever you have any patient coming to you who has persistent cough, okay, for around 3 months for 2 consecutive years, then you are going to label him as chronic bronchitis, and this chronic bronchitis is going to be associated with airway narrowing. Okay, airway narrowing like this. Okay, so here in COPD patients, we have 2 patients. One is going to be a blue fatty and a thin pinky. Okay, so we have 2 peoples. One is going to be a blue fatty, another one is going to be a thin pinky, and you should be able to identify who is a blue fatty, who is a thin pinky. Okay, who is he? Blue fatty. Okay, blue fatty involves larger airways, that is chronic bronchitis. Thin pinky involves the smaller airways, and it is smaller airway or alveoli emphysema. Okay, emphysema. This is very, very important. Okay, very, very important. So what is the difference between chronic bronchitis and emphysema? Okay, emphysema and chronic bronchitis. Okay, this emphysema is also called as type A COPD, and chronic bronchitis is called as type B COPD. Okay, how the lung will be in emphysema? Hyperinflated lung. In chronic bronchitis, the lung will be usually normal. Okay, how these patients will be built? They will be thin built. Okay, and these patients will be fatty or chubby. Okay, in emphysema, okay, what is going to happen? They are going to be dyspneic at rest because of increased work of breathing. Okay, these people are not dyspneic at rest. Not dyspneic at rest. Okay, in these patients there will be increased work of breathing. Okay, here there will be normal work of breathing. Normal work of breathing. Okay, in these patients we saw PaO2 is normal at rest, but here there is hypoxemia, so PaO2 will be decreased at rest. Okay, now these patients, okay, who had a VQ match, okay, VQ match, when they exercise, what is going to happen? When they exercise, more amount of air is going to go inside, but perfusion is not enough. When perfusion is not enough, what is going to happen? They will start desaturating. இல்லையா? VQ Vயும் கம்மியா இருக்கு, Qவும் கம்மியா இருக்கு. திடீர்னு எக்ஸசைஸ் பண்றாரு, அப்ப மோர் ஏர் உள்ளார போகுது. அந்த போர் ஏருக்கு தேவையான ஹீமோகுளோபின் கொடுக்கிறதுக்கு perfusion இல்ல. So patient will start desaturating. Okay, whereas in patients with chronic bronchitis, okay, what happens? There is going to be VQ mismatch. Okay, அங்க perfusion நார்மலா தான் இருக்கு. Okay, but ventilation கம்மியா இருக்கு. Whenever he exercises, what is going to happen here? The airway caliber, whenever there is an exercise, sympathetic stimulation will be there, the airway will open up. Okay, when airway open up, some amount of air will go inside, so that VQ will try to match. Okay, so these patients PaO2 will increase on exercise. Okay, exercise. So because of this VQ match, okay, normally these patients will be pink in color. Okay, because of the VQ mismatch, normally these patients will be blue in color. Blue in color. Okay, then next is chest X-ray. So we will discuss the chest X-ray again, but here the chest X-ray will show hyperinflation. Okay, there will be hyperinflation, hyperinflated chest X-ray. Okay, and emphysema, here and there what you are going to see? Lot of bullae and pneumothorax. So they will have bullae and pneumothorax. Okay, whereas our patient with chronic bronchitis, so what is going to happen is there is going to be increase in the bronchovesicular markings. Increased bronchovesicular markings. Increased bronchovesicular markings. Okay, in chronic bronchitis, the patient can develop pulmonary hypertension. Pulmonary hypertension chances little more in chronic bronchitis, but pulmonary hypertension chance is comparatively little less here. Okay, so this is the difference between emphysema and chronic bronchitis. And one more X-ray finding, what you can see is, so we'll see there in X-ray. Okay, anyway. Okay, so this is the difference between chronic bronchitis and emphysema. Okay, chronic bronchitis and emphysema, this is difference. Okay, so what is the important thing you have to note here? They are dyspneic at rest here, dyspneic at rest, not dyspneic at rest. PaO2 is normal at rest, PaO2 is decreased at rest. One important difference. So copy it. Okay, so this is the difference between emphysema patient and chronic bronchitis patient. Okay, one more thing if you want to add, what will happen to the DLCO here? Decreased. Here DLCO will be normal. DLCO will be normal. Okay, so these are the two people. Okay, chronic bronchitis. Okay, so chronic bronchitis patient will have blue, fatty, and here it is going to be thin, pinky. Okay, one more thing which I can tell you is, one ஒரு patient வந்து impress பண்ணனும்னா there are certain ways to impress the patient. Okay, so impressனா to gain confidence. Okay, so one thing is, whenever a patient is smoker, you can see sometimes lips will be nicotine stain, fingers will be nicotine stain. அது வந்து heavy smokers. Okay, sometimes not a so heavy smoker, but he smokes actually, and whenever he comes for routine investigation, when he shows the blood report, okay, usually CBC தான் first காமிப்பாங்க இல்லையா? When you see the CBC, the first thing you will see hemoglobin. Okay, second thing is PCV. Okay, ரெண்டு hematocrit பார்ப்போம். நீங்க எப்பலாம் CBC ரிப்போர்ட்ல ஹீமோகுளோபின் பார்க்கும்போது ஹீமோகுளோபின் 16 or 17 in a male patient. Okay, அடுத்தது பேஷண்ட் கேட்கலாம், ஸ்மோக் பண்ணுவீங்களா? Okay, because chronic smoking, okay, even around 4 cigarettes per day will start stimulating the erythropoietin production, and this erythropoietin production will increase the hemoglobin. Okay, and the hemoglobin will be more than 16 or 17 in patients who are smoker. Okay, So that is one thing which you will give you a clue that this patient is a smoker. Okay. So what is the examination findings in patient with COPD? Okay. So whenever your patient is coming to you, what will happen is the patient will have a barrel-shaped chest. Barrel-shaped chest. Okay. And usually their accessory muscles will be active. Accessory muscles will be active. Okay. And they will have prolonged expiration. Prolonged expiration. To maintain the prolonged expiration, what they do is they used to sit in a characteristic posture called as tripod posturing. Tripod posturing. So what is this tripod posturing? Okay. நீங்க எப்பவுமே வந்து ஒரு கவர்மெண்ட் ஹாஸ்பிட்டல்ல சில டைம் இந்த வயசான கிராமத்துல இருந்து வர பேஷண்ட்ஸ் எல்லாம் பாத்தீங்கன்னா இப்படி உட்காந்துருப்பாங்க. நீங்க நிறைய டைம் வில்லேஜ்ல ஸ்மோக் பண்ற தாத்தாஸே பாத்தீங்கன்னா குத்துக்கால் வச்சு உட்காந்துருப்பாங்க. ஓகே. This is called tripod posturing, Indian tripod posturing. Okay. What happens in this Indian tripod posturing is they try to fix their diaphragm. Okay. When they fix their diaphragm, they will increase the expiration time so that there is no hyperinflation of alveoli. Okay. So they want to increase the expiration time. Adanala vande they will sit like that. Okay. That is called as tripod posturing. Okay. So in Western countries, the tripod posturing is like this. Okay. They will sit in chair, they will stoop forward. Okay. They will sit in the chair, stoop forward, and their hand will be fixed. Okay. So they will fix their diaphragm so that they increase the expiration time. Okay. Expiration time. I'll show you here also. This is actually tripod posturing according to books, but Indian patients இதை நீங்க காமன் அப்சர்வ் பண்ண முடியாது. Indian patients வந்து பெட் மேல they will be sitting over the bed, they will be sitting folded legs, they will be holding their legs. That is called Indian tripod posturing. Okay. But on a Western countries, this is the tripod posturing. Okay. And these patients will have pursed lip breathing. Okay. What is pursed lip breathing? நீங்க எப்பவுமே பேஷண்ட்ஸ் பாத்தீங்கன்னா பேஷண்ட்ஸ் இப்படியே பிரீத் பண்ணுவாங்க. pursed lip breathing na, you know, Indian female சுருக்கு பை இருக்கு இல்லையா, சுருக்கு பை, that mouth will be like this. Okay. So they will increase the expiration time to maintain the atmospheric pressure equal to the lung pressure. They will keep that pursed lip breathing and prolong the expiration. Okay. So they are going to have pursed lip breathing. Okay. Pursed lip breathing. Pursed lip breathing. Okay. And if you see their chest will be barrel shaped chest. Barrel shaped chest. You can see here also. It is actually transverse diameter equal to AP diameter. Okay, that is barrel shaped chest. Okay. இப்போ இந்த செஸ்டே பாத்தீங்கன்னா barrel shapeல இருக்கும். So this is barrel shaped chest. You can see here. Barrel மாதிரி இருக்கா? Barrel shaped chest. Okay. So this is barrel shaped chest. Okay. Transverse diameter is equal to AP diameter. Okay. And these patients are going to have pursed lip breathing. Okay. Pursed lip breathing. Okay. Pursed lip breathing. So a lot of times you can see this kind of patient in your ward. Okay. So this is called as pursed lip breathing. Okay. Pursed lip breathing. Okay. They will purse their lip and breathe. Okay. This is very, very important. Okay. You can notice in this patients. Okay. And what is this one? நீங்க யூஸ்வலா எந்த ஒரு பேஷண்ட்டும் கிளினிக்கலா பெட் சைட்ல போய் பாக்குறீங்கன்னா, so you should have few ideas. Okay. So there are different ways of approaching patients. Okay va, patients வந்து you can approach in different ways, and that will be unique for everyone. Okay. My way of approaching a patient will not be the same thing for another physician. Okay. So approaching patients, there will be certain markers in the patient which will readily give you clue for diagnosis. Okay. So if you see this patient, what is this one? You can see the retraction of the muzzle. inspire பண்ணும்போது muscle has to come out, but it goes inside, and this is called as Hoover sign. Hoover sign. What is Hoover sign? The paradoxical indrawing of the chest wall during inspiration is called as Hoover sign. Emphysematous patients do not usually have polycythemia. They do have, okay, but it's more common in bronchitis, but emphysematous patient can have. Okay, so there is a paradoxical indrawing of the chest wall. Paradoxical indrawing of the chest wall. Chest wall called as Hoover sign. Hoover sign. Okay, so how we are going to diagnose a case of COPD? Diagnosis is based upon symptoms and risk factors, followed by you're going to go for spirometry. Spirometry. Okay, whenever you do spirometry, you are going to get obstructive pattern, where you are going to have FE1 by FEC ratio less than 70%. Okay, and DLCO is normal except emphysema. Okay, except emphysema. Okay, now if you see here, it's okay. Okay, you can approach a patient in this way. Okay, now a patient is having spirometer being done and he is confirmed the case of COPD, and what you are going to do is you are going to assess the patient and you are going to divide the patient into A, B, C, D. Okay, how they are divided into A, B, C, D? Okay, first is MMRC scale. Okay, MMRC scale, you have two different kinds of MMRC scale. Okay, one is Modified Medical Research Council scale, another one is Medical Research Council scale. Okay, so in Modified Medical Research Council scale, you have 0, 1, 2, 3, 4. Okay, 0, 1, 2, 3, 4. Okay, what is 0? Okay, what is 0? Now, whenever you are on exertion and you develop breathing difficulty, then it is going to be grade 0. Okay, grade 0. Okay, then what happens? The patient is climbing stairs. Okay, climbing stairs. Then he developed breathing difficulty. Then it is grade 1. Okay, then what happens? He walks with his peer group. Then it is grade 2. Grade 2. Okay, then patient develops breathing difficulty on walking 100 meters. Okay, 100 meters. Then it is going to be grade 3 and at rest grade 4. Okay, usually how I will tell my in clinics is, so you have your college and medicine ward. Okay, college ஒரு இடத்துல இருக்கும், medicine ward இன்னொரு இடத்துல இருக்கும். Okay, so posting ஆரம்பிக்க போது, okay, previously this pattern was there. Okay, when posting is there and if you are late means you will not be allowed inside the posting. இப்போ எப்போ வேணா வராங்க, எப்போ வேணா கேஸ் எடுக்கிறாங்க. Okay, so now college. Okay, well, your friend is waiting in the medicine ward. Okay, so உங்க friend வந்து கிளாஸ் ஆரம்பிக்க போறாங்க, சீக்கிரமா வாங்கன்னு கூப்பிடுறாங்க. So the student is rushing. Okay, class 0 exertion. அதுக்கப்புறம் வார்டுக்கு படிக்கட்டு ஏறி வராங்க, கிளாஸ் 1. ஓகே, ஆர் கிரேட் 1. மேலே உங்க ஃப்ரெண்டை மீட் பண்றாங்க, ஃப்ரெண்டுக்கு மூச்சு வாங்கல, உங்களுக்கு மூச்சு வாங்குது, கிரேட் 2. ஓகே, வார்டுக்கு நடந்து போறீங்க, ஓகே, 100 meters நடக்கிறீங்க, breathing difficulty grade 3. கிளாஸ்ல போய் உட்காடுறீங்க டெமோ ரூம்ல, breathing difficulty grade 4. Okay, so these are the 4 grades of MMRC scale. Okay, so this is MMRC scale. Okay, so MMRC scale you are going to use. This is MRC scale, but MMRC scale is important. Okay, then after that you have a questionnaire called CAT questionnaire. Okay, like how we saw ACT questionnaire in asthma, here we have CAT questionnaire. Okay, so it is COPD assessment test. Okay, so நீங்க என்ன பண்றீங்க, what you're going to do is you're going to give this questionnaire to the patient. The patient is going to tick the numbers and you're going to get a score. Okay, then if you patient is going to tick the score, you have two kinds of scoring, less than 10, more than 10. Okay, less than 10, more than 10. Okay, whenever it is less than 10, it is good quality of life. Okay, whenever it is more than 10, then it is poor quality of life. Poor quality of life. Okay, then next is you are going to spirometrically classify a patient for COPD. Okay, by definition, if a patient is having COPD, his FE1 by FEC ratio should be less than 70%. Okay, and he is further classified into mild, moderate, severe, and very severe. Okay, how he is going to be classified? Mild means FE1 is more than 80%. More than 80%. By definition, FE1 by FEC is less than 70%. Ana FE1 mattum more than 80% is going to be your mild case. Okay, then next is 50 to 80% moderate, 30 to 50% severe, and less than 30% is very severe. Okay, even though FE1 by FEC ratio is less than 70%, FE1 மட்டும் மைல்டா இன்க்ரீஸ்டா இருக்கு, then 50 to 80% இருக்கு, 30 to 50% இருக்கு, less than 30% இருக்கு. So this is mild, moderate, and very severe COPD. Okay, mild, moderate, severe, and very severe COPD. Okay, then next is number of admissions in the hospital. Okay, number of admissions in the hospital. If in this thing, okay, if you see here, so just patient had more than 2 admissions or less than 2 admissions. Okay, patient had more than 2 or less than 2 admissions. Okay, so that is very, very important here. Okay, so based on this, what you're going to divide is you are going to divide the patient based on symptoms and risk. Okay, symptoms and risk. Okay, so if you take here MMRC scale, and CAT questionnaire, that is going to tell the symptoms of the patient. Okay, whereas if you take your GOLD criteria, okay, or spirometry based scale and number of exacerbations, then it will tell about the risk of the patient. Okay, whenever you have any patient coming to you with MMRC scale, okay, MMRC scale, okay, around 0 to 1, he is considered as having low symptoms. Okay, whenever CAT questionnaire is less than 10, then he is considered as low symptoms. Okay, low symptoms. Whenever a patient has MMRC of more than 2, okay, more than 2, then he is having more symptoms. Whenever the CAT questionnaire is more than 10, then he is considered as more symptoms. Okay, more symptoms. Coming to GOLD and exacerbation. Whenever your GOLD grade is mild and moderate, okay, is considered low risk. Whenever his GOLD is 3 and 4, that is severe and very severe, is more risk. Okay, more risk. Whenever you consider the number of exacerbation, which is less than 2, more than 2. Okay, low risk, more risk. Okay, so based on the symptoms and risk, you are going to divide the patient into low and more. Okay, symptoms la வந்து MMRC less than 2, more than 2 னு வச்சுக்கலாம். CAT la less than 10, more than 10. Exacerbation la less than 2, more than 2. GOLD la 1, 2, 3, 4. Okay, so this is GOLD 1, 2, 3, 4. Okay, so we are going to have 4 GOLDs here. Okay, so based on this, you are going to divide the patient. Okay, now if you are going to plot the patient here, okay, what happened here? MMRC less than 2, CAT less than 10. What is the symptoms? Low symptoms. How is the risk? The risk is number of admission is less than 2. GOLD 1 and 2 and less than 2 admissions. What is that? Low risk. Leah. GOLD 1 and 2, number of admission is less than 2. Okay, low risk, low symptoms. Okay, whereas here MMRC is more than 2, CAT is more than 10. So here it is considered as more symptoms, low risk. Yes. அடுத்தது here GOLD 3, GOLD 4. Okay, number of exacerbation or number of admission more than 2. It is going to be low symptoms, more risk. And if you come to the last column, in last column, it is going to be more symptoms, more risk. So we have 4 group of patients. This group 1 is considered as A, B, C, D. Okay, A, B, C, D. Okay, A, B, C, D. Okay, and based on this A, B, C, D, you are going to divide the patient and you are going to put it here. If you see here, this is what A, B, C, D. Okay, so if you know this, then only you can decide treatment in COPD patient. Okay, so this is actually followed till 2022 end. Okay, 2023 la வந்து endல usually December la தான் gold guidelines usually release பண்ணுவாங்க. 2023 what they did is they combined C and D as E. C and D as E. Okay, so at present this year guideline says you have only 3 groups of people: A group, B group and E group. Okay, E group is where the patient has GOLD 3 and 4 and number of admissions more than 2 irrespective of the symptoms. Okay, this is the latest one, 2023. So according to last year, we have 4 groups of patients: A, B, C, D. But according to latest one, we have 3 groups of patients: A, B, and E. Okay, A, B, and E. Why this is important? Okay, why this is important? According to the COPD guidelines, the treatment varies for different groups differently. Okay, different groups differently. Okay, previously, if you take a patient coming to you with COPD and if he is between A, B, C, D, for A, the treatment is any bronchodilator. Go for any bronchodilator, okay, as the first step in treatment, okay. And usually what they do is they go for SABA, SAMA. What is SABA, SAMA is short-acting beta agonist, short-acting muscarinic antagonist. Short-acting beta agonist, short-acting muscarinic antagonist. That is A, okay. B is, whenever a patient comes in B, it is LABA or LAMA. In B group people, the first treatment what you're going to start is either a long-acting beta agonist or a long-acting muscarinic antagonist. Okay. In C, okay, C, the treatment is LAMA. The treatment is LAMA. Okay. If patient is not controlled with LAMA, then you will add LAMA with LABA. If you are not controlled with this, then you will add inhaled corticosteroid. Inhaled corticosteroid. Okay. In patients with group D, okay, group D, what you're going to do is you will start the treatment as LAMA plus LABA. If it is not controlled, then add inhaled corticosteroids. Add inhaled corticosteroids. Okay, add inhaled corticosteroids. Okay. Now, in this, one more thing is, in these patients who are belonging to C and D, okay, you can give prophylaxis with azithromycin. Okay, this is long-term azithromycin. They used to give for around 1 year. 1 year you can give azithromycin, and here azithromycin is not used as an antibiotic but as an immunomodulator. Immunomodulator. Okay. Then next is you can go for roflumilast. Okay, which is a phosphodiesterase 4 inhibitor, especially if the patient is a smoker. Okay, so this is the guidelines for ABCD treatment. Okay, அதுக்கு நீங்க உங்களுக்கு A தெரிஞ்சிருக்கணும், B என்னன்னு தெரிஞ்சிருக்கணும், C என்னன்னு தெரியணும், D என்னன்னு தெரியணும். Okay, but what happened is they changed the criteria in 2023 into ABE, and how they treat ABE is ABE. Okay, for A, the initial treatment is bronchodilator. So any bronchodilator you can go for. Okay, then for B, LABA plus LAMA. Okay, then E, LABA plus LAMA. Okay, and in this patient, if eosinophil count is more than 300, then you will add inhaled corticosteroid. And what they say is, try to use a single inhaler combination. Okay, patient first LABA with LAMA ஒரு puff, அடுத்தது steroid எடுத்து ஒரு puff, அந்த மாதிரி கொடுக்காம try to give combination drug as a single puff. Okay, single drug, that will increase the compliance. Okay, Okay, so this is the latest guidelines. If eosinophil count is more than 300, then you are going to add inhaled corticosteroid. Okay, inhaled corticosteroid. So this is the latest GOLD guideline. GOLD is Global Obstructive Lung Disease criteria or classification. Okay, so this is very, very important. Okay, so ABCD in pota, verisa ABCD in pota puriyadu. Okay, all your guidelines says ABCD alone or ABE alone, but you should know what is A, what is B, and what is E. Okay, then coming to the investigations. Okay, investigations. Okay. So if you take the X-ray here, okay, this X-ray is a X-ray of chronic bronchitis. Okay. Here in chronic bronchitis, what is going to happen? There is going to be increase in the bronchovesicular marking. Okay. If you take this X-ray is a hyperlucent lung. Hyperlucent. Okay. And if it is a hyperlucent lung, if you see, this is going to be more or less like a barrel shape. It is emphysema. Okay. And in emphysema, what kind of heart you are going to get? You are going to get a tubular heart. You are going to get a tubular heart. Okay. And one more thing, what you get to see here is, you get to see flattened diaphragm. Flattened diaphragm. Flattened diaphragm. Okay. And in these patients with emphysema, what you get to see here? What are these things? These are bullaes. Okay, you can see the bullaes. Bullaes. Okay, you can see the bullaes. Okay, so this is what you get to see in patients on investigation. Okay, next is what you can do is you can go for ECG. ECG. Okay, ECG. Okay, in ECG, in COPD patients, usually what you get to see is you get to see right axis deviation. Okay, right axis deviation. So what you have to do for right axis deviation, what you will see, which lead you will see? 1 and AVF. Okay, in 1 and AVF, if it is reaching each other, then it is going to be right axis deviation. Right, ECG class is override for you. Yes, so right axis deviation is reaching each other is right axis deviation. Okay, whenever the ECGs are reaching each other, then it is going to be right axis deviation. When they are leaving each other, left axis each. Okay, left axis. Okay, then next is, if you see closely observe this ECG. Okay, what you get to see here, one P wave is flattened. One P wave is little away. One P wave is little big. One P wave is little sharp. Okay, no P wave. Okay, whenever you get more than 3 consecutive P waves of different morphology, then you're going to call this as MAT. What is MAT? Multifocal atrial tachycardia. Multifocal atrial tachycardia. Okay, multifocal atrial tachycardia. Okay, so this is one feature you get to see in chronic COPD patients. Okay, chronic COPD patients. Okay, so this is the ECG finding. Okay, so apart from medical treatment, there are 4 important things which is the forerunners in treatment of patients with COPD. Okay, 4 important things which you will consider whenever you treat patients with COPD. Okay, so what are the 4 important things in any patient who are coming to you with treatment for COPD you will consider apart from medical treatment? The first one is smoking cessation. That is the first important thing. Okay, after smoking cessation or along with smoking cessation, you will advise the patient for LTOT. Okay, what is LTOT? Long-term oxygen therapy. Okay, then the third thing is flu vaccination. Okay, and the last one is pulmonary rehabilitation. Okay, so these are the 4 important things you will consider in any patient with COPD, okay, as a treatment option. Smoking cessations, okay. Whenever you plan for smoking cessation, what happens? You have to see how the patient is going to respond, okay. So whenever, if you take as age increases, usually the FE1 will decrease by 20 to 30 ml per year. Okay, as age increases, your FE1 will decrease by 20 to 30 ml per year. And if the patient is a smoker, if he is a smoker, then FE1 decreases by 50 to 60 ml per year. So smoking doubles the fall in FE1. Okay, so that much bad is smoking. And any patient who is a smoker, you have to ask for 5 years. 5 years. Okay, what are the 5 years you are going to ask? Okay, the first one is ask. Okay, ஒவ்வொரு தடவையும் பேஷண்ட் வந்து உங்க கிளினிக் வரும்போது ask the patient to stop smoking. Okay, ask to stop smoking at each visit. Okay, second A is advise the patient. Okay, the advice should be clear, strong, and personalized. And third is assess the patient. Okay, his willingness to stop. Fourth, assist the patient. Okay, plan stopping method, support him, and plan the pharmacotherapy. And 5, arrange for follow-up. This is similar to your CAGE questionnaire in alcoholics. Okay, you have CAGE questionnaire in alcoholics, like that. Here you have 5 years. Okay, so all these are from guidelines. Okay, so certain areas you have to follow guidelines. Okay, and respiratory medicine people, they blindly follow only guidelines. Okay, more than books. Okay, okay, so this is from guidelines. Even if you put gold guidelines in net, you can download the guidelines. Okay, so it is always based on guidelines. Ask, advise, assess, assist, and arrange. Okay, so what are the drugs which can be used for treatment of patients with smoking cessation? Okay, so first is you have nicotine. Okay, what this nicotine will do? The nicotine will stimulate nicotine receptor. Okay, and by doing so, it decreases withdrawal effect. It decreases the withdrawal effect. What is the side effect of the drug? It causes skin changes. Okay, usually you will have nicotine patches. Okay, nicotine patches. So it is cause skin changes, and it will result in vivid dreams. Okay, so here we have 2 kinds of patches. Okay, one is long acting patches. Okay, this long acting patch is given if a patient smokes more than 10 cigarettes per day. Okay, and this patch will be a kind of patch which is going to deliver 21 milligram per day. Okay, that patch will deliver 21 milligram of nicotine per day. If he is not a chronic smoker and he smokes only less than 10 per day, okay, then you will give a patch which is going to deliver 14 milligram per day. Okay, so this is patch. If he smokes more than 20 per day, you can go for Nicotix gums. Okay, nicotine gums. If he smokes more than 20 per day, then he can go for nicotine gums. Okay, nicotine gums. Okay, so this is the treatment option available in the form of nicotine gums and patches. If you go to any medical shop, in that display, they will have definitely Nicotex gums. Okay, so Nicotex gum is one which you can advise the patient. Okay, second is varenicline. Okay, what is this varenicline? This is a repeatedly asked question. It is a partial nicotine agonist at alpha 4 beta 2 nicotine receptor. Alpha 4 beta 2 nicotine receptor. Okay, so this drug, the side effect is it has suicidal thoughts. It has suicidal thoughts. Okay, then the last drug, which is going to be bupropion. Okay, this is a nicotine receptor inhibitor, and it is also a norepinephrine dopamine reuptake inhibitor. Norepinephrine dopamine reuptake inhibitor. Okay, it is decreases the seizure threshold. Side effect is it decreases the seizure threshold, and the extra point is it is contraindicated in seizure patients. Apart from this, we have nortriptyline, even your clonidine. Okay, clonidine can be given for smoking cessation. Okay, then cysteine. Okay, cysteine, there is not cysteine, cysteine. Okay, is a new drug which is approved for smoking cessation. But these are the commonly used drugs. Okay, commonly used drugs. Apart from this, we have nortriptyline, clonidine, cysteine. Okay, so this is available, and you also have e-cigarettes. Okay, but e-cigarettes is banned in India. Okay, e-cigarettes is banned in India. Okay, so this is the e-cigarette. Okay, this is how e-cigarette will look like. Okay, so this is a canister. Okay, which is battery charged. Okay, battery charged, and if you open it, you will have a rechargeable battery and a container which contains nicotine liquid. Okay, so whenever you inhale it, this battery will heat up the nicotine, and that nicotine will be inhaled. Okay, but it is actually banned now. Okay, in India it is banned. Okay, so this is different varieties of e-cigarettes are available. Okay, e-cigarettes are available. Okay, so this is the smoking cessation treatment. Okay, so this is the treatment for smoking cessation. Coming to next thing, which is going to be long-term oxygen therapy. I don't know why they have given this much space. Okay, okay, and the rehabilitations. Okay, so I'll write the vaccine. Okay, okay, long-term oxygen therapy. Okay, what is long-term oxygen therapy? Okay, long-term oxygen therapy is in a day around 15 hours. Okay, 15 hours you are going to give long-term oxygen to the patient. Okay, what is the indication for long-term oxygen therapy? The indication is if a patient is having a PaO2 of less than 55 or a SpO2 of less than 88%, then you have to give long-term oxygen therapy. Okay, the indication is PaO2 of less than 55, SpO2 of less than 88% is the indication. Okay, so யாருக்கெல்லாம் பேஷண்ட்டுக்கு for more than 3 months, okay, for more than 3 months they are persistently having chronic hypoxia in the form of decreased PaO2 and decreased SpO2, you will put the patient on long-term oxygen therapy. Okay, அதே certain indications you will start an early long-term oxygen therapy even though the PaO2 is less than 59 and SpO2 is less than 89. Okay, so even though the numbers are little, only 1 or 2 is difference, but this is very significant in those patients. Okay, so whenever your saturation is less than 89% persistently and PaO2 is less than 59% and the patient is having features suggestive of pulmonary hypertension, peripheral edema and polycythemia, then you will start early long-term oxygen therapy. What these features are suggesting of? Right heart failure or carpulmonary. Okay, whenever these patients are having these features, then you are going to start early long-term oxygen therapy. Okay, very, very important thing. Okay, so now how this long-term oxygen therapy is available? Okay, if you see this long-term oxygen therapy in our country during COVID, so many people were having this long-term oxygen therapy machine. Okay, oxygen concentrator. Okay, and it is available like this also in Western countries. It is available like laptop bags. Okay, so wherever you want, you can carry it, wear it. Okay, take oxygen for half an hour or 1 hour, then you can switch it off. Okay, like that it is available, and you also have oxygen canister. Okay, oxygen canister. Okay, so oxygen canister is actually during COVID, I don't know, someone gave me one oxygen, 3 oxygen canister. Okay, ஒரு flask மாதிரி இவ்வளோ பெருசு இருக்கும். Okay, what you have to do is you have to take it. Okay, ஒரு படத்துல செந்தில் in Indian, you will use perfume, right? Like that, you have to open the mouth and you have to press it, oxygen will go. But what's the problem is, actually I tried it once. Okay, to see how it is, it causes severe headache. Okay, it causes severe headache because it is hyperbaric compressed oxygen. Okay, and 1 2 after COVID, I think so, after COVID or before COVID, I'm not sure. So one day morning in Marina Beach, what they did is people were going for jogging and all. Okay, and there was one display booth. In the display booth, what happened is they kept oxygen canisters and they gave oxygen canisters to patient when people who are running there. Okay, as a promo for that company. Okay, and there will be a situation. Okay, there will be a situation in another 30 years or 40 years, definitely oxygen will be available in canister. Like how you take Coke and Pepsi, you have to put money, the canister will come, you will take oxygen. That will be a situation. It will happen in another 30 to 40 years. Okay, oxygen is, so who thought that oxygen will be available in concentrators? This does not require any oxygen supply. It will take the atmospheric oxygen, concentrate the oxygen alone, and it will deliver the oxygen. That is the machine. Okay. And during COVID, you don't, you know, or I don't know, I mean, you don't know what happened is people bought these machines and they kept in their home simply as a precautionary measure. Okay, as a precautionary measure. And this machine cost around 40,000 rupees. Okay, 5 liters oxygen concentrator. COVID time la, it went up to 2 lakhs to 2.5 lakhs, and there is a waiting period for that also. Okay, 40,000 rupees machine, 2.5 lakhs to 2 lakhs. Okay, so that is the demand when COVID was there. Okay, so this is one wonderful device which is going to help the patients on long-term oxygen therapy to survive. Okay, so usually every week we send one patient. Now it is available in rent. 1 month rent is 4,000 rupees. Okay, 5,000 rupees. So we send the patient. Like long-term ICU we are shifting the patient to ward means patient might require 2 liters to 4 liters of oxygen. So on the many patients during discharge, what we advise is we are telling them to get this on rental basis, use it in home during night time especially. Okay, so this is oxygen devices. Okay, then next is pulmonary rehabilitation. Okay, pulmonary rehabilitation. What is this pulmonary rehabilitation? Okay, so patient, because of shortness of breath, he is going to have decreased activity and decreased exercise. Okay, so what you are going to do is you are going to, after 3 weeks of discharge, you are going to train the patient for his exercise capacity. So patient should know how long he can walk without breathing difficulty, and when he should sit, how much time he should sit, and then again start walking. Okay, so this is very, very important in patients with COPD. Okay, then the last important thing is pneumonia vaccine. Okay, apart from pneumonia vaccine, you also have to give influenza vaccine, which is given every year. Okay, so whenever you have any patient coming to you with COPD, okay, what you have to do is, whenever the age of the patient is more than 65 years, okay, you have to give a vaccine called TPSV 23. Okay, this is pneumonia polysaccharide vaccine 23. Okay, pneumonia polysaccharide vaccine 23. Okay, so this is one important thing. Okay, in US like countries, it is compulsory that patients should get vaccinated. How you vaccinate for kids? You have to vaccinate adults up to 65 years with TPSV 23. Okay, and this, if it is going to be pneumonia, in pneumonia the schedule will be discussed, but here you have to know that after age of 65 years the patient should be vaccinated for TPSV 23, pneumonia polysaccharide vaccine. Okay, polysaccharide vaccine. Okay, so this is the vaccination available for patients with COPD. Okay, COPD, and it is very, very important to vaccinate the patients. Okay, then next is you have other devices. Okay, the first one is called endobronchial device. Endobronchial valves. What is this endobronchial valves? If this is the airway of the patient, okay, what you are going to do is you are going to fix a valve like this. Okay, this is a one-way valve. What happens is it will open during expiration, and during inspiration it will close. Okay, so this will keep your airway patent, and it will help to remove the excess air which is getting trapped. Okay, so this is called as endobronchial valves. Okay, so this endobronchial valves will open during expiration and it will close during inspiration, and it will prevent the excess air getting retained inside your lungs. Okay, lungs. So here this is the endobronchial valve which is available. So this is like a stent you place in the airway. Okay, this is called endobronchial valve. Okay, coming to next thing, which is going to be surgery. Okay, so here there are lot of surgeries which are options are available. Okay, lot of surgical options are available, but one thing what you can do is you can go for bullectomy. Okay, bullectomy. Okay, so what is bullectomy? Okay, if this is the lung of the patient and if the lung has bulle, okay, then you can remove the bulle, and the indication to remove bulle is if a patient has bulle of more than 1 centimeter, then it can be removed. Okay, which can be removed. Then the next thing what you can do is lung volume reduction surgery. Okay, then what is this lung volume reduction surgery? Okay, so if this patient is having a lung which has COPD, then you can remove the part of the lung. Okay, this is particularly useful in patients with upper lobe emphysema. Upper lobe emphysema. Okay. So lung volume reduction surgery is useful in upper lobe emphysema, and it is contraindicated or it is avoided in patients with FEV1 of less than 20%. Okay. Patient is having diffuse emphysema. So emphysema is not concentrated to one area, it is a diffuse emphysema. Okay. When DLC of the patient is less than 20%, patient having congestive heart failure and alpha-1 antitrypsin deficiency, in all these patients, lung volume reduction surgery is contraindicated. So you cannot go for lung volume reduction surgery. Okay, and this is particularly beneficial if the patient is having upper lobe emphysema. Upper lobe emphysema, in these contraindications, it is not much useful. Okay, the last resort available for any patient with COPD is going to be lung transplantation. Okay, so lung transplantation is based upon a scoring system called Bode index. Bode index. Okay. Okay, Bode index. Okay, what is Bode index? Bode index tells about 4-year survival rate. 4-year survival rate. Okay, 4-year survival rate. Okay, so here we have 4 important things. The first one is going to be BMI. Okay, BMI is the first one which is going to be taken into account. Second is O for obstruction in airway, which is measured by spirometry. Then third is dyspnea, which is assessed by MMRC scale. And the last one is going to be exercise capacity. Exercise capacity means the patient will be allowed to walk for 6 minutes. So இங்க ஒரு பாயிண்ட்ல இருந்து இந்த பாயிண்ட் வரைக்கும், which is around 100 meters, the patient will be told to walk for 6 minutes. Okay, 6 minutesல எவ்வளவு நேரத்துல அவருக்கு tiredness வருது இல்ல dyspnea வருதுன்னு பார்க்கணும். Okay, so that is called a 6-minute walk test. So this indicates patient is having exertional dyspnea. Okay, based on this you will decide whether the patient is eligible for transplantation or not. Whenever your Bode index is more than 7, then the patient has to be referred for lung transplantation. Okay, so this is the measures which can be taken in patients with COPD. Okay, COPD, very, very important thing. Okay, these are the measures which can be taken in patients with COPD. Okay, so this is again Bode index is very, very important thing. Okay, so this is based on the 4 parameters. Okay, 4 parameters. And what is this one? This one is bullectomy. Okay, remove the bulle containing lung. Okay, this is also again lung volume reduction surgery. Lung volume reduction surgery is done in patients who are having upper lobe predominant emphysema, and it is contraindicated whenever there is a diffuse disease. Okay, diffuse disease. And Bode index is based on these 4 parameters. What are the 4 parameters? B for BMI, O for obstruction airway, MMRC scale, and E for exercise tolerance. Based on this, you are going to decide whether the patient can go for surgery or not, and you will refer to surgery whenever Bode index is more than 7. Okay, so this is about COPD. Okay, so early LTOT means we don't have to wait for symptoms to be present for 3 months. The symptoms will be there. If the symptoms, COPD knowledge, symptoms will be there for longer duration. Okay. If the symptoms are persistent, okay, then you have to go for long-term oxygen therapy. You give symptomatic treatment. If the patient is not improving, then patient definitely have to go for long-term oxygen therapy to prevent further exacerbations.